The effects of otitis media on children's speech and language development. Other than the common cold, otitis media is the most frequent illness children suffer from during early childhood. Otitis media is an infection or inflammation of the middle ear, which is located behind the eardrum. When infections that cause sore throats, colds, and other respiratory problems spread to the middle ear, it causes an inflammation. According to the American Speech Hearing Language Association, an estimated $3 to $5 billion is spent every year on health care costs that relate to otitis media. There are various types of otitis media, and not all have symptoms. In acute otitis media, the middle ear infection occurs suddenly, causing swelling and redness. Fluid and mucus become trapped inside the ear, causing the child to have a fever, ear pain, and hearing loss. Otitis media without an infection is very difficult to detect because symptoms of pain and fever are not present. Oftentimes, weeks and even months can go by before parents suspect a problem. An earache can occur because the fluid in the middle ear pushes against the eardrum, causing great discomfort. Discharge from the ear occurs when the pressure from the fluid build up is very high, and it can cause the eardrum to rupture. When the eardrum ruptures, it allows drainage of the fluid from the ear. A child may experience difficulty eating and sleeping because of painful pressure changes in the middle ear. Other characteristics include a decrease in a child's activity level, child crying more than usual, fussiness or irritability, fever, vomiting, diarrhea, and vertigo. Pulling or scratching of the ears is usually characterized by infants. Hearing loss due to otitis media can be characterized by a child not being able to respond to soft sounds, increase the volume of the television, talk louder than usual, and are inattentive, especially in noisy surroundings. One might wonder why children have recurrent and persistent otitis media the first few years of life, and that is because of the size and angle of the eustachian tube. The eustachian tube equalizes the pressure between the middle ear and the atmosphere. The eustachian tube also allows the drainage of mucus from the middle ear into the throat to take place. When a child has a cold, the eustachian tube may also be blocked by congestion in its lining or by mucus inside of the tube. Normally, the middle ear is air-filled, but due to blockage, it allows the buildup of fluid to occur. This can cause bacteria to be trapped in the middle ear, and that is how ear infections can occur. When the middle ear is filled with fluid, the two muscles, tensor tympani and stapedius muscle, do not contract well. As a result, the three tiny bones in the middle ear, malleus, incus, and stapes, that carry the sound vibrations from the eardrum to the inner ear cannot transmit the sounds as well as they should, causing a temporary mild to moderate hearing loss. Temporary hearing loss can disrupt children's ability to process language at a fast rate, which affects both comprehension and production in phonology, vocabulary, syntax, and discourse. This, the children's auditory input due to the hearing loss can cause them to perceive information inaccurately into their phonological working memory, building up inaccurate representations of words. Children with prolonged or frequent otitis media are believed to become inattentive, especially in noisy situations, resulting in attention difficulties for auditory-based information. Academic achievement, particularly in reading and other language-based subjects, may also be affected. Children can also have poor self-esteem and social problems because of the hearing loss and the delay in their speech. One of the easiest ways to detect otitis media is by looking into the ear using an otoscope. This allows the physician to check the outer ear and the eardrum. If the eardrum is inflamed, red, cloudy, or bulging rather than being pearly gray, it means there is an infection. To check the fluid in the middle ear, the physician uses a pneumatic otoscope. A puff of air is blown into the eardrum to test the movement. If the eardrum does not move well, then it means there is fluid. The Goldman-Fristow test the articulation by sampling both spontaneous and imitative sound production at the word and conversation level. The Kahn-Lewis phonological analysis test helps to diagnose and plan remediation for phonological disorders. The preschool language scale tests a child's receptive and expressive language. The early language milestone scale focuses on receptive, expressive, and visual language. The Peabody picture vocabulary test is a useful screening for receptive vocabulary. Many physicians recommend taking antibiotics for an infection in the middle ear. Antibiotics do not work for infections caused by viruses. There are many bacteria that can cause otitis media, and many have become resistant to the antibiotics. This happens when a child is prescribed to take antibiotics for a cold, cough, flu, or viral infection. Antibiotic treatment is not useful for these situations. This causes a patient to try numerous types of antibiotics until the appropriate one is found. Amoxicillin is the #1 choice of antibiotic by most physicians. Even though the infection has cleared, the fluid can remain in the middle ear for several months. If the fluid remains for 3 months and is associated with a hearing loss, many physicians recommend the insertions of a tympanostomy tubes. This procedure is called myringotomy. During the procedure, fluid is drained from the middle ear by making a small opening in the tympanic membrane. The tube ventilates the middle ear and keeps the air pressure in the middle ear equal to the air pressure in the environment. The tube normally stays in the eardrum for about 6 to 12 months. An evaluation by a speech pathologist will be needed to see if the child has a delay.